Welcome to the Pro Aging Podcast. I'm Steve Gurney, founder of Positive Aging Sourcebook. We're excited that you can join us for our interactive discussions with pioneers and thought leaders on a wide variety of topics related to aging and longevity. Today we have an interactive panel presentation that will discuss end-of-life options with a focus on medical aid in dying. This is the medical practice that allows mentally capable, terminally ill adults with a prognosis of 6 months or less to live the right to die peacefully in their sleep. Leading this discussion, we have Donna Smith, the DC, Maryland Campaign Director with Compassion and Choices, Dixcy Bosley, a nurse case manager with Iona Senior Services, and Kate Vasiloff, a volunteer with Compassion and Choices. So let's jump into the discussion. Button. And welcome our panel members for what I am positive is going to be a thought-provoking and informative discussion for all of us. Today, we're going to talk about end-of-life options that include the medical aid in dying, which is often a confusing and misunderstood program that is across the country. We have some representatives in the Mid-Atlantic who are going to talk about these programs and give us an overview. So I'd love to bring on board from behind the curtain, Donna Smith, Dixcy Bosley, and Kate Vasiloff. So if you all want to turn on your mics and cameras. Great, we got you all here. Well, first, before we dive into this very important and can be a confusing topic to many people, let's get to know you all a little bit better. Donna, I've known you for years, so I'm going to start with you. Donna, tell us a little bit about your background and what led up to your role that you play now.
Great. Thank you for having us here today for this great discussion. My name is Donna Smith. I am a state director and a DEI advisor to Compassion and Choices. I graduated from GW Law School. I lived in Maryland most of my life. Prior to joining Compassion and Choices, I was a policy chief at the Maryland Department of Aging. And so aging issues have been a part of my career for the last 20 years. And this was just a great segue from the Maryland Department of Aging, because this is an issue that, although it affects people of all ages in terms of caring for loved ones at the end of life or dealing with end of life issues, the majority of the people I deal with around end of life are aging. And so this was just a great segue, because we know that everything is patient-centered and person-centered now, but it seems like end of life is the only thing that hasn't gotten to that point yet.
Great. All right. And I will go below Donna on my screen to Kate. Kate, tell us a little bit about you and your background leading up to your current position.
Sure. Hi, thanks for having me. I'm originally from Sarasota, Florida. I moved up to Virginia many years ago to go to school and loved it here and didn't feel like going back to the crazies down in Florida. I'm here in Virginia, in Arlington, just outside DC. In my professional life, I do research. I do surveys and focus groups on a variety of different topics, usually on more issue-based campaigns on environmental, on education, on reproductive rights, some really interesting stuff, both here and abroad. But today, my capacity here is a volunteer with Compassion and Choices. I got involved a year or so ago and have been talking to different groups around Virginia, trying to educate on medical aid in dying and why it's important to pass it here in Virginia.
Great. And last but not least, Dixcy, tell us a little bit about yourself, and then we'll dive into this topic.
Okay, thanks. It's great to be part of this conversation. I came to being an end-of-life activist by way of a lot of suffering as a nurse in the early AIDS days of the early 80s. And so I saw a lot of suffering, a lot of death, and it's been my career and passion ever since, to work with hospice, and now I'm a private geriatric care manager at Iona. hoping to engage people in the conversation of how to plan for a good death when you're still very well. So anyway, I'm so happy to be here today at this conversation.
Great. All right. So let's dive into this topic. And I know I've got the agenda here somewhere, but before we dive into it, I want to make sure that everybody, this can be a topic that brings up a lot of questions and conversation. And so feel free to make liberal use of the Q&A feature. Patricia McGrady is the winner today. And she says, will I be able to see the other attendees? No, because we've got over 100 people scheduled for this discussion. This is the Zoom webinar platform. And so you can communicate with the other attendees by using chat, but we wouldn't be honoring our speakers by doing this in a meeting format with 100 people on the screen. So that's, Patricia, that's the reason that we're doing it this way. But ask your questions, and then let's see. I believe, Donna, are you going first?
Yes.
Okay, so I have a PowerPoint for you that I'm going to bring up on the screen, and then I'm going to duck behind the curtain myself here, and you just say next when you want me to advance the slides for you.
Okay, if you shared it with me, I think I'm the host, I can't advance it. No, I can't. Okay, that's fine. So really great to be here once again. Let's dive right on in because Katie is coming after me and then Dixcy, and we have a lot of great information to share with you guys. But first about Compassion and Choices. Compassion and Choices is the oldest, largest, and most active nonprofit working to improve care and expand options for the end of life. We educate, we advocate, and provide end of life counseling. I think it's very important to understand that though advocacy is probably what we're known most for in terms of advocating for this medical aid in dying legislation across the states, that we also have an end of life education component where we go around presenting about other options at the end of life and just educating people about the need for healthcare directives and so on and so forth. That is really important, especially at this time. Next. So I'm going to start off by saying, this is a great quote from Dr. Atul Gawande's book, Being Mortal. Life is meaningful because it is a story. And in stories, endings matter. All of our endings matter. So overwhelmingly, multiple surveys have suggested, and this survey is from the Journal of the American Society on Aging in June 2015, that all of us, regardless of socioeconomic backgrounds and race and religion, we all would prefer to die at home with loved ones, with pain and discomfort managed, and having our spiritual values or other values respected. So when I talk about end-of-life options, we're talking about all medical treatment interventions. We're talking about discontinuing or refusing medical treatment, which is something you have a right to do in every state. We're talking about voluntary stopping of eating and drinking, another right you have in every state. We're talking about palliative care. Palliative care is sort of end-of-life care. It includes hospice and comfort care, palliative sedation, which is giving people enough medication to make them comfortable, but in some doses of this, people will pass, and that is known and that is accepted. But the intent of that is to make you comfortable, even though the result of that could be death. And medical aid in dying, which is a lot like palliative sedation. The difference is the intent is to cause one's death. So what is medical aid in dying? Medical aid in dying is a safe and trusted practice in which a terminally ill, mentally capable adult with a prognosis of 6 months or less to live has the option to request from their doctor a prescription for medication, which they can choose to self-ingest to end unbearable suffering and die peacefully. Next. Currently, this is law in 10 states. So that would be Oregon, which is where it was first implemented, Washington, California, Hawaii, Montana, New Mexico just passed this year. It's the latest one to pass. Colorado, Vermont, Maine, Washington, D.C. Next. So I'm giving you the overall picture, and then my other colleagues will go into depth in other states. But the Death with Dignity Act in DC was passed on November 15th, 2016. The DC Council enacted the law by an 11-2 vote. The law went into effect on February 18th, 2017, but because of the way the administrative rules were written and some of the back and forth with Congress, Republican members of Congress were fighting the law, people in DC didn't know the law had passed. So it took us probably until 2018 to start getting traction and get the word out that the law had indeed been implemented. These are some of the eligibility requirements for the laws, and these are common in all 10 states where it has been passed. You have to be an adult, 18 years or older, terminally ill, 6 months or less to live. So that's important. Let me restate that. We all know people who are terminally ill, but if you don't have that 6 months or less to live prognosis, then you are not eligible to use the law. It's important because this is the same 6 month eligibility that hospice uses. And so it's important that you have both of those requirements filled. And you must be capable of making medical decisions. Next slide. Other requirements include making sure that a physician informs the person about all end-of-life care options. There are 2 verbal requests separated by 15 days. Different states have different time periods requested, and 1 written request, but generally it's around 15 days. 2 physicians must confirm eligibility to use the law. So they must say that you have the mental capability to make this decision for yourself. If there is any hint that that is not the case, both of the physicians or one of the physicians must refer you to a mental health professional. So you need 2 witnesses to attest to the voluntary nature of the individual's request, and the person must be able to take and ingest the medication themselves. In most instances, that means swallowing the prescription. Yes, next. Other provisions of the law. In every law, it states that wills, contracts, insurance, and annuity policies are not affected. In every law, in every state where it's passed or where it's introduced, medical aid in dying is not considered suicide or assisted suicide. And that is because the disease is killing you. And it has been determined that has been determined by the 2 doctors, right? That you have, your primary and your secondary doctor. You are determining as a terminally ill patient the when and the where, but the disease is actually killing you. Next slide. So I know my colleague Dixcy is going to talk about more personal experiences, but I want you to know that there are different phases of the campaign. In Maryland, we're still trying to enact the law, right? So we're in the legislative phase in Maryland. In DC, we're in the access campaign stage, where we're educating the public, empowering individuals, educating the medical community and doctors about it, and providing technical assistance to hospitals and hospices to make sure they're aware of it and they help the patients that want to do this. Next slide. So I'm covering some stuff for Dixcy, so she doesn't have to do this. But in DC, these are the hospitals and the hospice, the one hospice that have policies that we call neutrally engaged policies, where if they have patients who want to be a part of this, they do have doctors on hand that can help you. So Sibley Memorial, George Washington, University, GW Medical Faculty, MedStar Washington Hospital, Vitas Hospice, and Kaiser Permanente are those. Now, we do not keep a list of doctors who do this because nobody wants to be on the Death with Dignity doctor list, but we keep on our Find Care tool a list of the medical facilities that have engaged neutrality policies. And each year we work with DC Health. We haven't done it since COVID, but each year we work with DC Health to train 180 medical professionals. So let's talk about Maryland really quickly. We first introduced the bill in Maryland in 2015. It was introduced in the Health, Government Operations, and Judiciary Committee in the House of Delegates by sponsor Shane Pendergrass, and simultaneously in the Senate with Senator Ron Young in the Judiciary Proceedings Committee. Each year, we gained more and more traction and introduced the bill. In 2019, the End of Life Options Bill passed the floor of the House of Delegates. It passed all the way through. It got out of the committee, got on the floor, passed out of the floor. It then went to the Senate committee, which is the JPR committee. It got out of the Senate committee. However, it died on the floor of the Senate in a 23-23 vote. That rarely happens. One senator could not decide what he wanted to do, and so he chose not to vote, and that's why it was a tie vote. In 2020, the bill was introduced, but because of COVID, the legislature closed early. And in 2021, the Senate sponsor of the bill, Jeff Wallstreicher, decided not to introduce the bill. We expect the bill to be introduced in 2022. Since the House of Delegates has already passed the bill, the Senate must pass the bill before it goes back to the House. We currently have done a count in the House and we still have the numbers to pass it in the House, but the Senate must pass the bill first before it'll go to the House now. Currently, we need 3 senators. Several senators have retired since 2019. That's why we went from 1 to needing 3 who were supporters of the bill. We are targeting several Senate districts and are organizing via phone banks and other digital organizing tools to make sure we get those 3. Next. How can you help? If you are a supporter of this, we certainly need you, number one, to talk to your doctor to see where they are on this. It's important that doctors hear from their patients who are in support of this. If you're in Maryland where it has not passed, we expect that it will pass either this year or next year. So it's coming. So it's important for you to have that conversation already. If you're in DC or Virginia, in Virginia, we know it's coming, and I know Kate is going to talk about that. So it's important for you to get a feel for where your doctor is, but having those discussions helps the cause because we need doctors to be aware of how important it is to some of their patients. We'd love you to volunteer with us. Come on board and help us. You can connect us with groups or organizations that would like a speaker to give a presentation. You can connect us with other medical professionals who want to learn more about the law, and you can always donate. I think that's it for me. If you have any questions, this is my email, Donna Smith at dsmith@compassionatechoices.org. It's also in the chat. Thank you.
That was great, Donna. Thank you. And let's see here. I think our next panel member who's up is Kate, and the questions are coming in. This is fantastic. I don't want anybody to think that we're not addressing these. What I think, because we've got some content to share, we will, let's get through these 3 presentations and then we'll have a great open discussion about all of this. So Kate, I think I've got a slide deck for you, correct?
Yes, you do.
Okay, so let me load that up and here we go.
All right. Well, thanks, Steve. And definitely thank you to you, Donna, for covering a lot of really great stuff. I'm just going to be talking specifically about medical aid and dying in Virginia, where we're at and where we're hoping to go and how you can help. So legislatively, in 2018, Delegate Kay Corey out of Fairfax, Virginia, her constituents were saying, this is something we really want here in Virginia. And so she said, great, let's look into it. So she commissioned the medical aid and dying final report through the General Assembly. And that was a sweeping overview of in which states is this currently legal? How is it working? What are the safeguards? A really in-depth report, and anything that's highlighted in blue is a hyperlink, and you can click on it, and it'll take you right to the report. But she liked what she read and liked what she heard. So in 2019, she introduced HB 2713, which is modeled after Oregon's medical aid and dying law. Oregon's, as I think Donna mentioned, Oregon was the first state to legalize medical aid and dying. It's been on the books for over 20 years. One of the really interesting things about that law is that written into it is that it requires an audit each and every year to analyze the conditions under which medical aid and dying medication was prescribed, how many people took it, all the metrics around it, what kind of diseases people had that brought that about, and importantly, looks at and investigates any ability or any possibility of coercion or abuse. And in 20 plus years that this has been legal in Oregon, they've had 0 cases of abuse, of coercion. There's been no need to revise the law. No one's even asked for it. So it's a really ironclad law. And that's what Virginia has modeled their legislation after. Unfortunately, in 2019, it didn't make it out of committee. 2020, Delegate Corey fearlessly tried again, and unfortunately, again, it didn't make it out of committee. So in 2021, due to the truncated General Assembly session, thank you, COVID, she was unable to introduce it again. So at Compassionate Choices Virginia, we decided to really make this an education year. We know that across the country, 75% of Americans support medical aid and dying. But we didn't know what they thought about here, just specifically in Virginia. And in talking with people anecdotally with our volunteer team across the Commonwealth, it's just not a very commonly talked about issue. So we've really taken this year to do this huge education campaign. I personally have spoken to over 36 different organizations just to talk about this issue, to show many people who are unfamiliar, maybe uncomfortable with it, that there are legal safeguards built in, that it is an option. This is not Death Panel 2.0 by any stretch of the imagination. This is just asking people to allow another option for those who want to choose it. We're not taking anything off the menu for anyone who may not want to ever investigate medical aid and dying. We're just asking for one more menu item to be on there for those who might want to explore it if the worst case possible situation occurs and you're diagnosed with a terminal illness. So 2022, we're keeping our fingers crossed. Delegate Kay Corey has given her word that she's going to introduce it again if she gets reelected. So we're hoping for that. And we also have some really significant interest in the Senate this year. So that's super exciting. So our goal of Compassionate Choices is to make the medical practice of aid and dying legal and accessible option in Virginia for terminally ill, mentally capable adults to make healthcare decisions at end of life. So very similar to what Donna was saying. So as I mentioned, we know 75% of Americans, and that's the Gallup poll, support medical aid and dying, but what do Virginians think? So fortunately, as I mentioned in my intro, that's what I do professionally. So we worked with our good friends at Christopher Newport University to do a poll of Virginians, and it's unbiased, third party. They did everything. We just supplied the question, and we found out, drum roll, please, slide.
Oh.
That 7 in 10 Virginians support medical aid and dying. And that transcends every gender, every age, every political persuasion, and very interesting and importantly, all different types of religions, particularly different types of Christians. So 2 things I want to point out here. One, look at that Republican support, 3 and 5 Republicans and 4 and 5 Democrats. I mean, that's pretty darn close. You know, in a time where wearing masks is politicized, vaccines are politicized, for an issue that is perceived as so third rail, so scary, to have a majority support from both Democrats and Republicans is really tremendous. With the different types of Christians, Catholics are oftentimes some of the most outspoken opponents of medical aid in dying, particularly for the legislators who, you know, they have the ear of. But look at that. We have 3 and 5 Catholics, even more Protestants, supportive, and general Christians, non-Catholic, non-Protestant, supportive. Like I said, I do data for a living, and I never see majority support this strong. Slide, please. So it just continues. All different ethnic groups, different regions of the Commonwealth, and different size cities, or communities, rather. So really, really strong support. So we're going to do this poll again coming up in a couple of months. Hopefully we'll see exactly the same, if not more, support. But we're also really hoping that this will give politicians the political cover they might feel they need in order to be supportive in a more public way. Slide, please. So what are the next steps and what can you do? Number one, please make sure if you live in Virginia, well, if you live anywhere, but particularly in Virginia, where medical aid in dying is not quite legal yet, that you and your loved ones have advanced medical directives and you've discussed end-of-life options. I know the Compassion & Choices website has amazing workbooks in both English and Spanish. They have even COVID addendums that you can work through, which hopefully we're nearing the end of needing those. But nevertheless, the last place you want to be having these conversations is in crisis. So please talk with your loved ones before crisis strikes about getting those advanced medical directives locked up. Consider signing the petition. It's an individual petition that just tells Compassion & Choices Virginia that you're in supportive of this, and then it gives us more leverage when we go and talk to politicians around Virginia. If you want to write directly to your Virginia delegate, please do so. That is a very effective way. And I guarantee you, each delegate is hearing from someone from Compassion & Choices pretty regularly. So dropping them a line would go a long way to know that it's not just this, you know, group of dedicated few who want this, that it actually is a Commonwealth issue. Talk to people in your lives about this issue. Increased awareness is the biggest driver of increased support. As I mentioned, it's not something that comes up very often unless you've personally been touched by it or you have a family member who has or had a terminal illness. It's a tough one, but it's an important one. And so just casually talking about it with those in your life just elevates the conversation and makes it more mainstream and not so scary, because it's not as scary. It's just another option. So just another way to give someone who has all their options taken away from them by a terminal illness a little bit of control, a little bit of dignity back. And then if you have any questions after the presentation or you want to get more involved with our efforts in Virginia, please feel free to email me. We have so many different opportunities to get involved, both online and offline, heavy lifts, light lifts, legislative work, talking to people work, email work, you name it. We'll find a way to leverage your skills and your interest to help us get the ball across the finish line here. We're very hopeful and optimistic that this year, if not next, we'll get this passed and have a legal option for people to peacefully die in the ways that they want if the absolute worst happens to them and they have a terminal illness. So again, happy to take any questions at the end, but that's it for me, Steve.
Great. Okay, so now our final panel member. Boy, we got a lot of questions coming in. They're looking good. We're going to get to those, but first, let's hear from Dixcy, who's, I think, going to share some real-life perspective.
So when we were planning this event today, we were talking about the importance of hearing stories to make it personal. And part of being a nurse is the privilege of the intimacy of being up close and personal to suffering, all the family dynamics and spiritual dynamics that go with that. And I've had a privileged career because I've spent my entire career in end of life care. And it's been quite a journey, but I've learned through my care with people with AIDS and also oncology patients that there's enormous suffering that sometimes is not satiated. And when people die in pain, shortness of breath, and agitation, it's traumatizing, not just for the family, but for caregivers. So I feel like my role, I said I'm an end of life activist because I feel like my role primarily is to be an advocate, to not just support patient-centered care, but patient-directed care. I want my patients to be in the center of their end of life journey. And like Donna said, life is a story, and how people's story ends is really important. It's important to them, and it's important to those who will be bereaved after they leave this earth. When people have a hard ending, it lingers for a long time. So as an advocate, I want people to know about the hospice Medicare benefit and when they're eligible and what the criteria is. And I also have learned, I've kind of evolved over the years to really want to know more about medical aid. I had heard about it, we called it physician's assisted suicide for so long, and that's not the proper name for it. It's medical aid in dying. And I've learned about what that means. And so about 2.5 years ago, I was asked by Compassionate Choices to accompany a patient. I had gone to the hearings in DC and learned about what the process was for the law passing in DC, just as a curious hospice nurse. And I strongly became an advocate and a zealot for this law, mostly as seeing it as a human right. The law has passed, and now everyone needs to be informed and aware that it's something that people have access to if they're eligible. So 2.5 years ago, Compassionate Choices asked if I would accompany somebody as a volunteer, not as their nurse. They already were under hospice. It was a lovely family, a 60-year-old gentleman who had exacerbated COPD, chronic pulmonary obstructive disease, and he was suffering on oxygen 100% for like 5 years. He had maybe a 75-foot cord that he was constantly connected to for 5 years. He had employment exposure to, getting this disease, and was really suffering. Had tried to take his life at one point and ended up in the ICU. And then after the bill passed, he thought that this is what he really needs to do. And accompanying him on this journey and learning about his life and his struggles really made me a convert. And he had such a beautiful death. And at the time of his death, there were children playing in the playground out the window. The window was open, and it was just the beauty of holding life and death in balance. And his family was extremely supportive. So that was my first experience. And then since then, a few other people have called, and either they were directed to call by one of the hospices, Vitas Hospice physician, called me to accompany a patient who was a gentleman who came from Arizona, and he came across the country and took residence in DC so that he could also take the medication. And being with him and his 4 siblings was a powerful experience of patient-directed care. He had suffered so much. He had advanced AIDS, but he also had cancer and was in insufferable pain. And somebody asked a question about palliative sedation, and ideally that is a good way to go if we can use it, but some people cannot take enough medication. It just seems like their pain is so great. Another couple was a 60-year-old woman who had Parkinson's, and she also had a very loving, supportive partner who did not want her to pass, but they had had many conversations about what the end would look like. And she was not at the end of her disease, but she was qualifying for hospice. And she met with the physicians, 2 physicians, and they qualified her to be able to get the prescription. And she also had a very gentle passing. I've recently have had a call from a patient in Virginia who is wanting to relocate in the district because Virginia does not have the law at this point. And so I'm just working with her. She's a younger woman with metastatic breast cancer. She's actually has gotten the prescription, but she's, not sure if she wants to use it yet. And so That is also an important piece, is that for many people, it's just a comfort to know that this is an option, that this is something in their toolkit that they can avoid the possibility of preventing suffering. And, I just feel in terms of the morality of it, I do not want to participate in enhancing anyone's suffering. Do not harm is my guiding principle as a nurse. And I want people to know that they have access and availability to medications that could end their suffering. And so for many people, it's just having the prescription is comfort enough. And then another patient I just want to mention was a very old patient. He was 98 years old, very competent, also on oxygen, extended disease. And he just made it really clear that this is what he wanted. And so he had a exquisite, beautiful end of life with his wife at the bedside. The physician was there. I was there just as an accompaniment, as a support. And his suffering ended. And he was very short of breath prior to taking the medication. So I just want to say that, the why of why I do this is because I really believe in justice and human rights. The who of why I do this are the teachers, are the patients who teach me about suffering, the doctors who are courageous enough to step forward and say, I will write the prescription. It's a legal prescription. The pharmacists who fill the prescription, the hospice workers who participate. Many are neutral, many are opposed to it, but these patients are mostly all hospice patients. And so we have to engage hospice in this process because our patients have the right to participate if they choose so. And the hows, we can talk about the hows of, the medication and what the process is. I'm happy to answer any questions about that. I've had to learn it myself, and it's been quite interesting. And then really what matters most to the patient is the essence of all this. People, I know many of us have had loved ones who have said to us, if I ever get in this condition, just give me a pill and let me go. Well, that's not legal, right? But if people qualify for medical aid, they need to know that that is available for them in 10 states. And I want to support Virginia's process in this. I think Kate's demographics show that many of the residents want it, and we are the people. We the government. So hopefully that will move forward for Virginia. I think that's about all I wanted to share, but I'm happy to answer any questions.
Great. Well, at this point, I'd love to bring all of our panel members back on, and we can start jamming through these questions here. Let's see. Fred asks, do you need to be a resident of the state in which the physician-assisted end of life is available?
Okay, I'd love to answer that. Number one is medical aid in dying, not physician assisted. The physician does nothing other than write a prescription, which they do when you see them for a cold. But yes, you have to be a resident of the state in order to get the prescription, and each state has its own residency laws. So you really need to look at that and make sure you can fulfill those residency requirements. Good question. Thank you.
Okay. And then Barbara says, why would people choose medical aid in dying over palliative sedation?
Well, I tried to answer that. Ideally, that actually happens a lot in hospice. We also do palliative weans in ICUs to help wean people off respirators. We need to, as folks who become ill and age, we need to be self-advocates and know that that's an option. And we need to let our doctors know when we want that. But sometimes that's not always an option. So it's just one of the choices that people have is palliative sedation.
So can I just add on to what you said?
Absolutely.
Palliative sedation is when they are treating you, quote unquote, for comfort, right? And they know sometimes as a consequence, people may die, but it's not the intention. The difference in the two is people can plan They can have family come to visit. They can get all of their wants and desires said and done. You know, I know one couple that Dixcy helped. The man wanted to end his life shortly after Thanksgiving because he wanted to see all his family and wanted them to have those good memories at Thanksgiving. So it is the intention and the deliberateness that provides some peace. The reason why you would choose medical aid in dying as well is it's not forced on anyone. So you as the patient can get the prescription and never use it. It's up to you. When you're dealing with palliative sedation, it's not necessarily up to you. It's up to the person that's assisting you and helping you. They have more of a say-so.
Can I just add on there too? Absolutely. And kind of to echo what we've said, it's to legalize it in any state, Virginia in particular, it's not taking away any other option that you currently have. It's just adding one for those who may want to explore it. And to, echo what Donna's been saying, this is a completely voluntary program from start to finish. Doctors don't have to participate. Pharmacists don't have to fill the prescription. Now, both of them do have to refer you out to a participating medical professional. But patients, by no means, need to explore this if you're not interested or in need. So it's really just adding one option for people who desperately want to explore it in a really horrible period of time in their life. And, as Donna said, 1/3 of people who get the prescription go home and never take it. I think Dixcy was right when she said there's a palliative care nature to from the mental health standpoint of even just having that prescription in your back pocket.
Great. Okay, let's see. The slide, I think, Donna, you had this. It said MedStar Washington Hospital is supportive in DC. Is that all of the MedStar hospitals, Georgetown, or only Washington Hospital Center?
Only Washington Hospital Center. Georgetown is absolutely not in support of it, as we expect them to be. The major opposition we have across the country for these laws comes from the Catholic Church. And so we don't expect Catholic hospitals to have this engaged neutrality.
And that actually,
in the poll, it's so interesting to see 3 in 5 Catholics in Virginia actually support it. So it seems to be quite the case that the people at the top have the loudest voices, but they're not necessarily reflecting the value of the members of their congregations.
And sounds like the reproductive health conversations as well.
Yeah, quite.
Yeah.
That ties in with a question from Wendy. It says the poll only included Christian religion. Is there a reason for that?
No, it didn't. The sample size for Jewish people and other religions was too small to pull out and display as the other Christians were. But the sample was representative of Virginians. So it just so happens that the majority of Virginians fall into those buckets. And so those were the ways to responsibly display the data. But if you're really interested in a particular religious perspective, I'm happy to provide it for you and look at the data.
Okay, great. And then Carolyn says, I'm in DC. What if your doctor does not want to do this?
Great question. So you may have to consider changing doctors. You could always ask your doctor for a referral as well, depending on the system they're with, but you may have to consider changing doctors.
I just want to speak out in terms of we need to do a better job as patients informing ourselves and informing our doctors and nurse practitioners about end-of-life care in general. Conversations that need to be done, advanced directives. The wonderful booklet that Compassion and Choices has is a great toolkit for us to be informed. And then we take that to our primary care provider and say, this is when I think I might qualify for hospice. I live in a state where medical aid is legal. I'd like to learn more about that. We need to teach our clinicians because they don't know.
Great.
And maybe they'll become providers in the future if patients demand it.
Right. And that's why it's important to have these conversations with your doctor now to see if they're on board or not, because the last thing you want when you're dealing with a terminal illness and treatment and options and things like that, doctors to find out that they're not going to be supportive. So it's better to ask and have those conversations now, if you're as a healthy person, to know that, you can build a relationship with a physician who would be supportive if, worst case scenario, this becomes part of your life.
Great. Okay. And then Kate or Patricia is following up with Kate. Can you name the Virginia legislators who are supporting and those who are undecided? And then should we also be talking to the senator about medical aid in dying?
No, and yes. I don't have a list off the top of my head. To be totally transparent, I am on the outreach public speaking volunteer side of things. There's a whole legislative team that keeps much better track of that stuff than I do. I know that they're having meetings weekly with legislators, and behind closed doors, there's a lot of support. Because we don't have a bill being introduced yet, people haven't felt the need to come out publicly. So I can't point you to a list with that respect. I do know we are making tremendous headways, and hopefully we'll have a more concrete answer for you soon.
Okay, and I just dropped your email in there just
Perfect.
For folks to be on your radar. Just to restate a question that was asked earlier, Martha says, what are the residence requirements for medical aid in dying? And you need to be a resident in the particular state that you are requesting this, correct?
Yes.
Is there a period of time that is required to be a resident? So could somebody potentially move to Oregon if they sort of saw, or DC, if they saw something like this in their horizon?
So each state has its own residency requirements. For example, I believe in Maryland, I think you have to be a resident for 6 months or so. In DC, it's not related to time. You have to produce about 20 different, you have the option of producing 2 out of 20 different, like utility bills, cable bills. There's all types of options you can submit to them to prove that you have a residence. A lease, you have to have at least 2 of these items, and they give you 20 different options, but it's not related to a length of time.
Okay.
And then just to underscore how serious people are, this gentleman that I knew from Arizona, he was in so much suffering that he requested his siblings to come out there and caravan across the country with him, supporting him in active pain along the way, to come to reside in DC, so then he could elicit a doctor and get under hospice care here and do the whole process. And I just was like, it was profound suffering that he left his home to do this. And the commitment of his siblings to support him was just profound to me. So that's an example of how desperate people are, is that they would travel across the country.
I'm trying to consolidate questions. This is from Francis and Marcia, but so we know the residence requirements is dependent on each state, but does your doctor have to be practicing in that particular state? And then also, is there a way for a prescriber to be a CRNP or a PA, or does it have to be can it be any type of medical doctor?
I think it has to be a physician. I don't believe a nurse practitioner or PA can write the prescription.
So it's dependent on the state. So example, in Hawaii, there are nurses that can write the prescription. Just because it's an island, you don't have access to doctors. So that's a unique situation in Hawaii. In general, Dixcy is right. In the continental United States, most of their laws say it's a doctor, but you have to check the state that you're looking into. The other question, Steve, was what? I'm sorry. I wanted to address the first one.
It was, shoot. I lost track of it. I think we've addressed it. Let me jump back to some of these other questions, and I'll swing back on that. Let's see. Someone asks, I know it's probably miles down the road, but I wonder when there might be options for people living in senility, which is a long, slow death with no clear end that I know of.
So that is what at this time is called the slippery slope, right? Because the protections of this law ensure that no one can force this on you. And that's why part of it is you have to have the mental capability to make your own healthcare decisions. And if you're using this language, quote unquote, see now, you don't have that mental capability to make that decision for yourself. And so that's a hard road to toe. And I'm not sure that I see that in the future. Because we have to make sure it protects people who need to be protected.
Mm-hmm.
Yeah, you can see in some other countries where the laws have been broadened, where it's got even more confusing. And I think the way that this platform has been developed with the 6 months is helping minimize going down those slippery slips. Let's see, has medical aid and dying been possible for people with COVID in DC?
So, Dixcy, you want to address this? You want me to?
Yeah, I mean, many patients have gotten under hospice care, but no patients have addressed that option with me. But I don't know. I don't know of any.
In general, COVID, in terms of the majority of these patients have ALS, cancer, long-term. Right. And so COVID is, and compared to this, is very quick.
Mm-hmm.
And to my knowledge, I haven't been aware of anybody with COVID who has been able to use this option because of the 6 month requirement for hospice, because of the 2, this process can take anywhere from 4 to 6 weeks, period, as it's written. And so COVID really doesn't fit the scenario under which this would be an option for folks with COVID.
Well, and I could be wrong about this, but I don't think COVID is technically a terminal illness.
Disease.
It could exacerbate an underlying condition that you may already have had, like a heart condition or a kidney condition or something like that. And that may cause you to become terminally ill. But COVID itself is not a terminal disease.
Okay, great. And then let's see, does palliative sedation always lessen the pain?
Dixcy, that's a good question for you.
Well, ideally, I mean, in hospice, when we had an inpatient unit, we would help people with palliative sedation. Also, in the home setting, if you have a great team of the nurse and the family supporting, you can always add more narcotic to help folks really endure the suffering that happens when you move toward end of life. There is kind of a transition period that's very uncomfortable. So palliative sedation is used. It's really, I think, very effective. And, the numbers show not many people in DC have used this law because they do have other options, but it's just the fact that the law exists. And so my role as a nurse is to let people know about that option. But palliative sedation is very effective. But it does have its limitations, and it also can be very prolonged. I have three or four hospice patients right now under my care, and the family's trying to palliate her, and I don't know if they're doing a great job. She's now unresponsive, and it's hard. It's a challenge. It's like childbirth. It's a long transition.
Great. We've got about 3 minutes, and I believe Kate may have to jump off at 1, but I'm going to keep on going till we get all these questions answered. And so anything that's in the queue, we'll go over it. Kelly Miller says, I would be interested in hearing more about how these conversations go with hospice providers.
Mm-hmm. Believe me, it's really hard. And the folks that I have been with, I've asked who their hospice nurse is, because I know hospice nurses and I know some of their backgrounds in terms of views on this. And so my recommendation to them is that we continue with the hospice care. They on a parallel track, they work with their doctor, get the prescription, and then they go through with their decision. And then after the death, we call the hospice nurse and say the patient's died. Sometimes the hospice nurse will be aware of what happened, but the patient on the death certificate, it is the disease, not the medication that took their life. And that's very important. They're under hospice care because they have a terminal illness, and the medical aid is just moving things along faster so they can limit their suffering. So I've felt some judgment from the hospice nurses because they might know why I might be there. And that's, I think we all need to evolve around this. And I don't, my job is just to treat help the patient.
Yeah. And this is another follow-up to that. It says, are hospice care workers trained to tell the family that their loved one is asking to go, and that the patient feels that the family is holding them here and not letting them go, letting them move on? So many hospice workers say this to the family. So I guess probably a lot of your outreach for this is educating hospice and palliative care workers.
Yeah. And also educating family members. Like when you pick your healthcare proxy, you pick somebody who's going to support what you want and not what they want for you. There's many couples who do not want to see their loved one go. And, each of these clients that I've worked with, I have witnessed so much incredible, generous love because they don't want their loved one to go. They're like, well, we can keep on going on the same path that we're going on and extend your life longer. But it comes a point where the patient says, if you love me, you will allow me to do this. And I've seen it happen. And it's a beautiful gift to help someone have a good death. And so we just need to kind of like the whole access campaign that Donna talked about is that we need to help our clinicians and the general public understand what it's about. And then it's a patient choice.
Well, death is incumbent upon us all, right? It's one of the few things other than being born that we all have in common, right? And we need to normalize the discussion about death because it's going to happen whether we want it or not, no matter how much we pay for insurance or not, no matter where we live, it's coming. And so what I like to tell people as I go around the nation and I present on these topics is that talking about death ain't going to kill you. That's not what's going to kill you, right? But not preparing for it and not preparing your loved ones about your values at the end of life could hurt for generations. Mm-hmm. And so, as Dixcy so eloquently said, the beauty of these laws, or Katie, I'm sorry, I don't remember which one said it, is that if it's not for you, it's not for you. And we as an organization would fight for anybody's right not to use it. But what we don't want is for someone's values to be more important than mine if this is an option that I want and need at the end of life. But we found in states where this is law, talking about death in terms of talking with your physician and what your other options are, people are opening up. The doctors are opening up. People are learning more about other options they have. And so that's part of this process. We have to normalize it. We have to have those discussions. You don't have to use the law, but we have to begin to talk about end of life issues.
Great. Okay. We got a few questions here that might get things going here. Could you expand upon and talk about insurance, life insurance, death benefits not being a problem for a family to collect a death benefit or for a family member if somebody chooses this option?
Well, in the states, in the city, DC, where this has become law, it's in the law that this is not considered suicide. And as a result, contracts, wills, insurances do not consider it that. And we have not had any issues with insurance policies not being paid because the person, as we have stated before, is dying from a terminal disease. And that is buttressed by the two physicians who certify that.
Great. And let's see, does caring and compassion have a form to fill out if you've been diagnosed with dementia, but are still capable that could be used if you decline?
I'm not sure that I understand the question.
I guess like if somebody was diagnosed with early Alzheimer's, is there a way to sort of say, if I decline to a certain point, then I'd like to activate the end of life?
So dementia is a problem in terms of medical aid and dying, but there is a dementia clause, and Steve will send you the link electronically to our planning guide on end-of-life options, which has a dementia clause in it that talks about how you would like to be treated, right? We'll send this out, we'll send this to you and you can send it out. But dementia and medical aid and dying is a problem because at the time you meet with your physicians, you have to have that 6 months prognosis, right?
Okay.
And you have to be mentally capable at that point of making that decision.
Yep. And Dixcy, you've got the document.
This is an amazing toolkit that I use with all of my clients, regardless of what we're going to talk about. I just think it's a great tool, but there is a dementia provision in there. And when people tell me, I work with a lot of clients who are part of the Georgetown Memory Clinic and their early, cognitive impairment diagnosis, and they want a mild MCI, and they want to start talking about like, what is the end of the disease going to look like for me? And so I'm like, you need to keep talking about what you want when you are no longer able to identify people who love you so that they can represent what your wishes are. If you get to the place where you're incontinent, unable to walk, and you're physically declining as well as mentally declining, maybe you don't want to treat some of the acute infections that you're going to get. Maybe you don't want to spend your last few weeks or months in the hospital. And you can identify those desires in this form. And it's so critically important.
So while medical aid and dying may not be an option for you, those other end-of-life options I listed are certainly options.
And
that's great.
And there are so many safeguards with this, like youth cannot use it. Mentally disabled cannot use it. People with dementia. The woman that I work with Parkinson's, she anticipated that she would lose her muscular ability to take the medication, and that she would also maybe lose some of her cognitive abilities. So that's why she decided to get the prescription and decide whether she wants to use it when she comes impaired.
Great. Okay. And then let's see, I'm going to there's a statement here, palliative means palliative sedation, treating you for comfort, sometimes a consequence, people may die. This feels so complicated. Have good memories for Thanksgiving holiday season, get the prescription and never use it. I think this is a statement is an illustration of how what you were just saying, everybody has different thoughts on this and different opinions, but if this exists and you don't agree with it, does it change your life in any way? I'm wondering,
Well, I think just introducing the concepts of like palliative sedation, people don't even know what palliative care is. Like being in an ICU and having an intubation, a wean off an resuscitation ventilator. Like people don't know what their options are. So the more we can have open dialogues like this program today, going to death cafes and folks talking very casually about experiences of end of life. Like Donna says, it's a real taboo topic. And the more we can have conversations about a plethora of conditions that people can enter into, that this is really critically important to have the conversations now and to understand what the terms mean.
Great. And then someone says, and I agree, how did you all get so comfortable talking about this and normalizing this discussion about death?
Well, for me, it was witnessing a lot of death and witnessing a lot of bad deaths. And I'm so committed to helping people have a good death because it does linger for many, many, many years if we witness people that we love struggle. So it complicates our grief. So anyway.
For
Great.
me, it was can I say this real quick? 30 seconds, I'll be quick.
Mhm.
For me, it was a discussion with my mom when I was 20 years old. My father died when I was about 20, 21, 22, and I was just traumatized. I was not prepared. We had never talked about it. And half jokingly, but really kind of seriously, I told my mom, I love you so much. If anything ever happened to you, as long as the hospital pays the electric bill, you will be alive and I will be somewhere visiting you. And my mother, who is everything in her church but the pastor, you know, she's a very spiritual woman. She looked at me and said, you better not. I was shocked, Steve. I said, what do you mean, Mom? You don't want to be with me as long as I want to be with you? She said, absolutely not. When it's time for me to go, you better let me go. That was important. That was an important conversation.
That is great. Let's see. Okay, I think I got through the questions, but we've got somebody in the audience. Oh shoot, why did I forget his name? With the film, the PBS film.
Joe Fobb. He was a producer of Joe Fab, When My Time Comes. I think he's going to share.
Uh-oh, I don't see him in the audience anymore. Joe, if you can raise your hand. I'm not sure if you're calling in. We'd love to spotlight you. If not, I can send out information about the film. It looks wonderful. And
I can just say that it's Diane Ream's book, When My Time Comes, and then there's an accompanying documentary through PBS. I highly recommend it. She interviewed many people on both sides of the discussion, and doctors and clergy and you know, individuals and, you know, general garden variety folks who die and ask them their feelings about this. And it's just a fantastic book and movie.
Okay, and then I do have a hand raised here. It's Francis here. I'm going to click on that. Sometimes this is a mistake. Francis, if you intended to raise your hand and ask a question. Oh, she dropped her hand there. Okay. Whew, boy, this was a good one, wasn't it? I really think that I want to first off thank our audience for such great questions, our panel members for bringing up this topic. And yeah, I think I echo one of the statements about being comfortable talking about death is it's death and taxes. They're two things that are very defined in our life. And if we can't talk about both of them, we've got a problem. We're avoiding it. And you guys have certainly set a great example about how to talk about what can be a difficult discussion topic that shouldn't be a difficult discussion topic. I'm going to post this recording ASAP this afternoon on proaging.com. I'll upload it as a podcast so you can listen to it while you're walking your dog. And I will make sure to post any links that our panel members would like to share with the audience as well.
Thanks, Steve.
Oh, you bet. And let's see, Patricia asks how many attendees were here. We had over 100. So this was a pretty good, well-attended discussion today. And with that, I am going to close things out, and we will be talking to everybody soon.
Bye. Thank you guys so much.
Thank you.